I'm Dr. Ken Landau. This is Well Now Doctor. Thank you for joining us. We're going to be discussing back pain, and we're going to be discussing how it interacts with the opioids, with the pain medicines, with the medicines like Oxycontin and the medicines in the Oxycodone, hydrocodone family. Are you likely to receive significant relief? Are they really beneficial? Do they improve the outcome of back pain in general? Are they likely to be associated with some kind of complication? If you take the drug, you're likely to continue taking it for a long period of time. You're likely to become tolerant or dependent on the drug. Is there really a difference between dependence and addiction to the drug? If you take the drug, are you likely to have some complications? Complications that might be relatively mild, or maybe you're going to suffer significant constipation. Maybe they're going to lead to depression. If you're a man, what's the likelihood of your suffering erectile dysfunction, impotence, if you take the drugs? If you take the drugs, are you likely to get back to work more quickly than if you don't take the drugs? Are the drugs really demonstrably better than just those over-the-counter medicines that you can take, the medicines in the family of the naproxen or the ibuprofen? Here in the United States, we have a tendency to believe that prescription medicines are better than non-prescription medicines, whatever they are, whatever the purpose. That's not necessarily the case. We also have a tendency to believe the more expensive the medicine is, the better it's going to work. Again, not necessarily the case. If we talk about back pain in general, extremely common. Most of us at some point in our adult lives are going to suffer some kind of back pain, either neck pain or low back pain. And as a matter of fact, that's the significant cause of activity limitation and people not being able to go to work, workplace disability. And even if you don't work, significant problem with disabling back pain. It's going to interfere with your ability to carry on your normal activities. Back pain is a major cause for seeking medical help, and we know overall back pain has a significant impact, an impact on individuals, an individual's ability to function. It's going to have a significant impact on the healthcare system in general, how the healthcare system interacts with people, how we perform surgeries. Do we need surgeries? Are too many people being operated on? And it's going to have a significant impact on national economies. We know that a significant number of people not going back to work, significant number of people on disability, significant number of people not going to have the same standard of living, not going to be able to enjoy their lives. Obviously, back pain a major problem. And as a matter of fact, if we look overall at the narcotic pain medicines, the opioid pain medicines, more than half of them are prescribed for people who have back pain. And we know if we look at the likelihood of receiving a prescription, if you happen to be in the United States or Canada, it's 2 times greater that you're going to receive a pain medicine for one of the opioids, a narcotic pain medicine, than if you happen to live in Europe. How effective are they? Well, at least if we talk about acute pain, the effectiveness is sort of inferred from other kind of problems where you have acute pain. Whether they really translate to back pain is questionable. And there are more issues associated with back pain that we have to consider. So if you take a narcotic pain medicine, are you more or less likely to return to work than if you take a nonsteroidal anti-inflammatory, a naproxen or something like that? Well, there's some evidence that actually the treatment for pain may impact on your ability to get back to work. If we look at chronic low back pain, not acute low back pain, but now chronic low back pain, are the medicines likely to help? It's interesting that we have very little evidence for the medicines being what we call efficacious, really working. We have some randomized controlled trials. That's supposed to be good news, but unfortunately they were highly selected patients, not like the people who are getting the drugs out in society now. There was a high dropout rate in most of the studies, and the studies tend to last for only a couple weeks. So yes, maybe they help the pain part. But remember, part of the disease is your ability to be able to function. And as a matter of fact, their ability to improve your function is nebulous. We don't really have great information that that's indeed the case. And as a matter of fact, some studies suggest that if you take the narcotic pain medicines, you're going to be less likely to be able to function. And as a matter of fact, when you take the pain medicines, everyone thinks that, my goodness, I'm going to take the pain medicine and then I'm not going to have any pain. I'm going to be pain-free. But that's not necessarily the case with the opioids or the narcotics. Seem to improve the pain by maybe about 30%, not 50%, not 100%. You still have the pain. It's still in the background. But it's not going to necessarily get rid of it. And as far as the long-term safety, we see so many people in the course of routine practice. I see people every day who have been taking the medicines for 1 year, 3 years, 5 years. They take them because the doctor gave them to them because they had some back pain at work in 2003 or something like that. And they're still taking the medicines. Question is, do we know anything about the long-term safety, long-term efficacy? Well, as a matter of fact, that's unstudied and unknown. And as a matter of fact, people who take the medicines for a long enough period of time are going to have some problems with the medicines. You're going to become tolerant of the medicine. So instead of taking one pill every 6 or 8 hours, now you're going to be taking 2 pills, now 3 pills. Some people considerably a lot more. And then as a matter of fact, sometimes the pills interact with the body in a way that causes what we know as hyperalgesia. The pain pills can actually cause more pain. So we got a series of issues with these medicines. And then we have the problem of addiction. A lot of people who take the drugs, especially who take the drugs for a period of weeks to months, are going to become addicted to the medicines. Not going to be able to get off the medicines without having a variety of other symptoms. They start to taper, they develop some symptoms, they assume that the primary disease that they were taking them for is returning, and they can't get off the medicines. But it wasn't that the pain is coming back, it's that the complications of getting off the medicine are making matters worse. And then we have another issue. It's sort of glossed over. We worry so much about when a small number of people are injured by the airbags in cars. We worry about the tires. We worry about the gym sets. They cause a small number of people to die. And that's something that we should look at. But these drugs, these narcotic pain medicines cause somewhere around 16,000 or 17,000 people to die every year. That's a major cause of death. That puts it in the major top 10 group in the United States. And we seem to be spending little effort, little discussion about that. In short term, when you take these medicines, they're going to have complications. There is no question that they're going to have complications. They're going to have complications like constipation, a significant impact on people's ability to function. How many times when you discuss pain control with people, are you going to find people complaining that they have constipation that really is bothersome? They cause belly pain. They're going to have nausea. They're going to have sedation. They're going to have difficulty with their ability to stand and walk. A significant number of people, especially the elderly, taking these medicines for back problems, obviously more back problems in older people. Well, as you become older, you have more of a likelihood of falling and fracturing a bone. And if you take the drugs for a long period of time, there's issue with depression. It seems that depression has a tendency to cause pain. Pain then generates people taking the narcotic pain medicines, but the narcotic pain medicines tend to cause depression to get worse. And if you didn't have depression when you started taking the drugs, oftentimes you're going to develop depression anyway. So we have a vicious cycle. And then there's an issue of sexual dysfunction for both men and women. But you hurt your back at work and you're a guy. You start taking these drugs, next thing you know, a delayed reaction, going to be suffering from erectile dysfunction. So what do we need? We need more selective prescriptions. We have to pick the people appropriately who really need these medicines, and we have to use the medicines for an appropriate period of time, and that's not 4 years and 5 years and longer. We have to be able to monitor people, monitor the prescriptions, make sure the people who get the medicines are really the ones who are taking the medicines, and we have to, most importantly, avoid other kind of medicines. Remember the studies that were done to show the medicine supposedly worked. Well, they were done in people who were not taking sedatives, who were not taking the narcotics with the sleeping pills, the anti-anxiety medicines. They weren't drinking a lot of alcohol. Have to consider all of those things. And then we have to make the medicines, formulate them in a manner that would preclude them or avoid them being able to be smoked and snorted and injected. Well, the opioids. Opioids are the most common class of drugs that are currently prescribed for back pain, for neck pain, and for low back pain. And as a matter of fact, we know that probably about 50% of the people who are regularly using the opioids, at least 50%, are doing it because they have back pain, in spite of the fact there's little evidence that the medicines work and that they get you back to work and that they help you. So, are the medicines appropriate? Well, it's tough to say, but the answer appears to be no. The drugs as used in the United States right now are used inappropriately. How common is back pain? Well, if we look at back pain, we find that about 1 in 4 people on surveys, 1 in 4 people, adults, over the period of the past 3 months are going to complain that they had at least 1 day of back pain. And if we survey them for a year, we find that about 50% of the people are going to complain that they have some sort of back pain, and 20%, 1 in 5 people, are going to report that the back pain is chronic. It frequently reappears. They don't seem to be able to shake it for a long period of time. And if we go to a family doctor's office, so now we're selecting people instead of the general population. Now we go and look at the people who have pain and severe enough to go and see a medical practitioner. We know that just within a month, within 1 month, 30 days, 60% of the people are going to get better, almost irrespective of what's done. We could do nothing. 60% of the people are going to get better. We can use back manipulation, chiropractic manipulation, 60% of the people are going to get better. Acupuncture, 60% of the people are going to get better. We can use drugs, 60% of the people are going to get better. Almost anything, 60% of the people are going to get better. 10% of the people are going to go on to develop chronic pain. Chronic pain is going to be defined as pain for more than about 3 months. And we know that a small percentage of the people are going to have some issues that are intermittent. The diagnosis of back pain, that's a problem. In order to treat something, we have to know what we're treating. And the question is, with back pain, what is it? Well, a lot of people say, well, it's my degenerative disc disease. Hooey to that. For the overwhelming majority of people, if we were lucky enough to do an MRI before they suffered from pain, and then one after they suffered from pain, we find that there isn't any difference between the two. Yet, if we only do the MRI after a person complains of pain, we say, my goodness, it looks abnormal. This must be the problem. On the other hand, we know that the problems oftentimes antedate. They come before the pain. So if the only test we have is afterward, the test is abnormal, then we say, aha, that's the cause of the pain. However, we know that the overwhelming majority of adults, and the older you get, the worse your spine is going to look on an MRI or any other kind of imaging test. We know that the studies are often unnecessary and provide not just false information, they provide misleading information. Because we simply assume that the abnormality we see on the MRI or on the X-ray is the cause of the problem, when indeed it existed long before. So is it the disc? Is it the vertebrae? Is it some problem with the musculoskeletal system? We just really don't know. Just don't know. And since the cause of the pain is unknown, it's kind of difficult to go and use a medicine that is just a painkiller to treat a disease, to treat a condition, and we don't really know why the person has the condition. And as a matter of fact, there's considerable evidence that maybe it doesn't have anything to do, in many cases, with some structural abnormality. It's well known that mood disorders, people who have depression, people who have anxiety, are much more prone to develop back pain. And then the question is, Is it really back pain, or is it a manifestation of the mood disorder, or is it a manifestation of the depression? And then we have some workplace issues. We know that a happy workplace seems to have less back pain than an unhappy workplace. More stress, more strife in the workplace, more uncertainty in the workplace, less ability to control what's happening in the workplace, greater incidence of pain. So it seems that the pain, the low back pain, the concept of low back pain, has to be taken with a grain of salt. And now we really view the whole problem as a biopsychosocial problem, a problem well beyond simply some sort of an abnormality in the bone or in the joint. Now, a lot of people worry, well, maybe the back pain is something serious. It's got some sort of major medical issue. Maybe the back pain is caused by metastatic cancer. Maybe it's caused by an infection in your spine. Maybe it's caused by something like that. Well, the likelihood of that is fortunately less than about 1%. Very unusual situation. If we look at sales of narcotics in the United States, the medicines that we doctors prescribe for people who have pain, well, in the past period of about 10 years, it's increased by about fourfold. Interestingly, the reason that prescriptions started to increase was because they weren't used enough. So back in the 1960s, 1970s, early 1980s, there was a problem, and people who had legitimate reasons to take these medicines, they were dying, they had cancer, they were in the final stages of cancer, they had acute pain. Well, there was the fear that they would become addicted, and a lot of people did not prescribe the medicines appropriately. They were used too sparingly. And as a result, because of the lack of medicine, a lot of societies came and said, well, that's inappropriate. You have to go and treat pain more humanely. And then all of a sudden, there was a massive upsurge in the number of prescriptions being written. And now, in the period of the past 10 or 15 years, the expenditure on these drugs has increased by more than 600-fold. Increased because of the price of the medicines. They've gone up. Everything seems to have gone up. They've gone up a whole heck of a lot. And the use has gone up. The percentage of people who have either neck pain or lower back pain, who see doctors, who get prescriptions for narcotics, back in the 60s, 70s, 80s, and even 90s, was less than 20%. Now it's 30 or 40%. And as a matter of fact, if you have back pain, chances are probably about 40% that you're going to get a prescription for a narcotic if the pain goes on for a period of 6 months to a year. And as a matter of fact, probably close to 90% of all of the narcotics, the narcotic pain medicines that are prescribed, the opioids, well, they're prescribed to people who have long-term back pain. And not only are they prescribed for these patients, the dose that the patient is taking gets higher. So you have a certain amount of pain. It's controlled initially with a certain dose, but later on you have that dose that might be doubled or tripled or quadrupled. There's a problem. The pain isn't getting worse, but you're taking more medicine. Well, if we look at the likelihood of prescriptions here in the United States versus prescriptions in Europe, as we said, it's about twofold greater than it is in the United States versus, let's say, England. It's about threefold greater than it is in Holland. But if we look at the comparison of the United States to Japan, well, in the United States, it's 26 times more narcotics that are prescribed on a per capita basis than in Japan. And here in the United States, if we look at some of the insurance plans, let's say for low-income individuals, did you realize that there's about a 23-fold variability throughout the country, just throughout the United States, on the likelihood of receiving the medications? As I said before, in the 1980s, not prescribed a whole heck of a lot, and then all of a sudden, pain experts told us that, well, we should really prescribe the medicines more frequently, and not only should we prescribe them more frequently, and more freely, but they said that there wasn't really a problem with the medicines, and if you didn't have any kind of pain or you didn't have any kind of problem, you wouldn't take the medicines. I think that proved to be false, unfortunately. And in the 1990s, there was a massive increase in advertising from the pain medicine manufacturers. They would sponsor different events, CME credits. They would help institutions write guidelines and societies write guidelines that would tell other doctors how to prescribe the medicine. And unfortunately, that wasn't at arm's length. And as a matter of fact, it sort of culminated when the makers of Oxycontin, Purdue Frederick, were indicted and charged with criminal conspiracy, criminal events, because they were claiming that the drugs really had a lower abuse than their competitors, when indeed they didn't. They were misbranding the drug. And as a matter of fact, when it gets right down to the issue, well, there's a lack of evidence of safety and efficacy of these drugs. And when it gets right down to it, we don't know how much to prescribe. We don't know what the appropriate dose is for any given individual. So let's divide back pain into two groups, acute low back pain and chronic low back pain. Acute low back pain, you would say that would be relatively easy. All of a sudden you have pain. You have lower back pain. It just seems to come on relatively quickly. Go to see the doctor. What is appropriate? Well, actually, we don't have any great long-term studies or even short-term studies that show that these medicines that are so widely prescribed are really any better than taking Tylenol or a nonsteroidal anti-inflammatory drug, an aspirin, an ibuprofen, or a naproxen, or one of the similar prescription kind of medicines. Is there any evidence that the narcotics are really better? And are they better than muscle relaxants? Are they better than antidepressants? We don't know that. We don't know that. And there's an issue. It isn't just how we treat the pain, it's how we treat the person. So the person is not able to work. Are we able to get the person back to work better if we use a narcotic drug than if we use a nonsteroidal anti-inflammatory drug? Well, the answer is it doesn't seem so. And actually, the narcotics, the Oxycontin and drugs like that, and the hydrocodone and drugs like that, they might actually inhibit some of the ability of the person to go back and function normally. And we know that a person, if they receive an opioid for more than 7 days, they have a relatively good good chance of being disabled after a year and still being on the drugs. And if we see people who have been taking the drugs for more than a couple weeks, well, those people have a longer likelihood of being disabled from work, unable to get back to work. And that's even if we adjust for work characteristics, people characteristics, all of those sorts of things. So the bottom line is, are these drugs really providing an appropriate function? Are they benefiting or are they causing problems? Well, we know that people are going to have a longer disability with the higher dose that they take. The opioids can worsen the outcome. We know that people who are taking the opioids seem to suffer from inactivity. When they become inactive or relatively inactive, then one of the things that's going to happen is the muscles are going to become weak. They're going to become relatively deactivated. The mood is going to be somewhat more apathetic. And as that happens, then the people are going to be negatively impacted, not positively impacted. And that's for the acute low back pain. Now let's talk about the chronic low back pain or the chronic neck pain. Again, the evidence that the opioids are going to be helpful is very meager. It's inconclusive. We have no trials that have lasted a long period of time, and the trials that have been ongoing, well, they suffered from high dropout rates. And as a matter of fact, the high dropout rates were because people didn't see any benefit and they had some side effects of the medicines. And the kind of people who were taking the medicines aren't the kind of people who were in the studies. The kind of people who are given the medicines in our society are completely different. They're psychologically different. These are people who have a higher incidence of other symptoms, mental symptoms, depression. They have a higher incidence of using narcotics, the hypnotics, the anti-anxiety medicine, sleeping pills. We know that there's an adverse selection to the people. So these people are not those pure people who are otherwise unencumbered by medical problems. People who are taking these pain medicines are taking an awful lot of other medicines as well, oftentimes. And the question is, how do they react with one another? Well, that hasn't been studied. And as a matter of fact, we already mentioned that people who are taking the pain medicine, they're going to have some reduction in the pain, but they're not going to have a complete elimination of the pain. So if we look at what happens overall in observational studies, we find that a significant number of the people who are taking the drugs are going to have a little bit of improvement as far as the pain is concerned. They're going to have less improvement as far as function is concerned. And as a matter of fact, the longer time goes on, the higher the dose of the medicine that they're taking. And in a Danish study, looking at the opioids, the narcotics, the oxycodone and the hydrocodones, and they looked at the people who were taking non-narcotic medicines. The people who were taking the narcotic medicines seemed to have a higher incidence of pain, increasing pain, and decreasing quality of life, in spite of the fact that the people, at least when they started, had about the same amount of pain. And if you take the medicines for a long enough period of time, you're going to find at least two things happen. One is tolerance occurs. Tolerance, you need more medicine to get the same effect. And then we find that there's something known as hyperalgesia. Hyperalgesia is a condition where the pain actually is increased. You have some changes in the central nervous system, and now you have increased pain, not decreased pain. And as a matter of fact, when we look at people who are able to successfully taper the drugs over a period of about 3 weeks, we find that the people who are off of the drugs have less pain, they have less depression, and they have greater function. So again, people taking the drugs for 2 years, 3 years, 4 years, they're addicted to the drugs, and the drugs are decreasing, not increasing their quality of life. And then you become dependent on the drugs. You become dependent, and that can take as little as several days or even several weeks. And unfortunately, when you try to stop the drug, you develop other kinds of symptoms that are misinterpreted for the primary pain problem that you had initially, so you don't want to get off the drugs. Yet the initial problem is gone, and now the symptoms associated with tapering the drugs are associated with the dependence. And what kind of problems do you have with dependence? Well, you can divide dependence into the psychological realm and the physical realm. In the physical realm, you can have agitation, you can have a problem sleeping, you can have diarrhea, you can have excess salivation, you can have extra pain. And all of that is because of the changes that have occurred in the central nervous system that have made you now dependent on the drugs. And as far as psychological dependence on the drugs, when you slowly taper the drugs or stop the drugs, you find that you lose any interest. You become flat in affect. You have dysphoria. You just don't feel good. You have cravings that you have to go and get some more of the drugs. Well, we know that even one dose of the drugs can have some negative impact. We know if we give a person hydrocodone or oxycodone and then give them an injection of the medicine that blocks the effect of the drugs, those people are going to have some sort of symptom, some sort of withdrawal symptom. How long does it take you to become addicted to the medicines? Well, for the average person, maybe around 1 month of taking the drugs or 2 or 3 months of taking the drug, and that can do it. We have a problem with the opioids as far as overuse is concerned. You take too much. Remember, the longer you take them, the more you're going to need to get the same effect. You have misuse, people taking them for reasons that they shouldn't be taking them. And then we have the opioid use disorder. That's the term that's now used for addiction to the drug. Addiction to the drug means that you compulsively seek the drug, you have dependence on the drug, and you take the drug and you go and search for the drug despite the fact that the drug has negative consequences, either physical or social or psychological. Now, is there a difference between physical dependence and addiction? Yes, technically there is, but doctors argue about it, psychiatrists argue about it, and I'll tell you, if the experts can't come to an agreement on it, it's not something that we really need to worry about. What's the likelihood of your becoming addicted to this and long-term users? Well, the addiction is going to occur in up to maybe 30% of the people. That's in addition to the people who are suffering from dependence on the drugs. It gets very murky. Well, the question is, if we assay people and assay the urine of people who are getting prescriptions for, let's say, hydrocodone, Oxycodone, and we measure the urine, see what's in the urine, see if our drug's in the urine in an appropriate amount. Interestingly, that more than 20% of the time, there's some sort of an abnormality. The abnormality is that either the people don't have any of the narcotic in the system. In other words, the narcotic has been diverted before they take it, so they're not taking the narcotic that they were given, or there's some other kind of a prescription medicine or some sort of an illicit medicine in the urine, and that happens very commonly. And long-term users, as I said before, have a higher incidence of having some sort of other issue. These are the people who are substance abusers. These are the people who are using things that they shouldn't be using, or they have mood disorders that makes them more susceptible. And we know that these people are more likely to get the drug in the first place, and these people are more likely to misuse the drug and become dependent on the drug and use the drugs over a long period of time. And then we have the deaths from the drugs. People worry about little things in life. Yes, they're very severe. Yes, they're important. We worry about people getting shot with BB guns, and we worry about people who are shot with bows and arrows, and we worry about people who are injured in schoolyard accidents, and we worry about all of these things. But right in front of us, right staring in our face, 16,000 to 17,000 people are going to die this year because of opioids, because of the narcotics, because of prescription narcotics. And that's a major problem. Once upon a time, it was thought that you could start taking them at a relatively low dose, and as tolerance developed, you could take more, and you could take an increasing amount of the medicine without causing any problem, but that's not the case. And especially it's not the case if you happen to be taking other kinds of drugs. If you take those sedatives or the hypnotics, or you take the sleeping pills, or you take those kind of medicines, or you take alcohol, you have an increased likelihood of causing yourself significant and serious harm. And interestingly, after spine surgery, people who are taking the drugs, taking these narcotics, well, the most frequent cause of death within 3 years after fusion, probably taking the narcotics. So medicines that we have to be very concerned about. And are the people who are taking the most narcotics, or people taking the infrequent narcotics most likely to have issues? Well, interestingly, it might be that the people who take the drugs infrequently are more likely to have problems. But if we look at the people who are taking the narcotics versus the people taking those aspirin-like medicines that we call the nonsteroidal anti-inflammatory drugs, the ibuprofen and the naproxen, the people who are taking the narcotics, people who are taking the opioids, people who are taking the oxycodone and the hydrocodone have a higher incidence of heart disease, higher incidence of fractures, higher incidence of bowel obstruction. And if we look at some of the other complications of taking these drugs, constipation, only have to give the medicine to 4 people, and one of them is going to complain of significant constipation that's going to significantly impact them. And then these drugs cause sedation and dizziness. Dizziness, major cause of falls and fractures, especially as we grow older, but young people are not immune to the problem. And as a matter of fact, if we look at people who are taking these drugs, well, the incidence of motor vehicle accidents increases significantly because people have reduced reaction time, reduced attention. They have what we call psychomotor retardation. And depression is very common. depression causes pain, and pain is treated with narcotics, and narcotics cause pain, we have a vicious cycle. So we increase the pain, we increase the dose, we increase the duration of therapy, and we increase the depression. That's a major issue. And as far as the hormone therapy or hormones are concerned, unfortunately, we know that the drugs, the family of narcotic pain medicines, affects the endocrine system. In the hypothalamus, there's a chemical that's released that tells the pituitary gland to make a chemical to tell the ovaries or the testicles to work. And it seems that the narcotics negatively impact on the hypothalamus, so now the hypothalamus isn't making the GnRH, the gonadotropin releasing hormone, the releasing factor, and it's not telling the pituitary to make its chemical, the gonadotropins, and as a result, men suffer from decreased testicular function, decreased testosterone, and they suffer from erectile dysfunction. And women, equal opportunity employer, women are going to suffer from a significant impact on the ovarian function. And as a result, they're going to suffer from amenorrhea or oligomenorrhea, not having periods or having periods that are relatively infrequent. And if we look at people who are taking the drugs, after they have the surgery, what's the likelihood of them being able to get back to work? Well, it's not nearly as good as it would be if they weren't taking the drugs. And as a matter of fact, the strongest predictor of risk of problems with these drugs may well be not the pain severity, but whether the person drinks alcohol or takes other drugs. And we have alternatives to these medicines. You don't have to take the narcotic pain medicine. Maybe there's cognitive behavioral therapy that might work in this case or that case. And exercise therapy. We say, oh my goodness, you have the back problem, shouldn't exercise. Well, maybe exercise is going to be able to reduce the amount of pain, reduce the recurrence, and reduce the likelihood of disability. So we ought to consider some more exercise. And then what about some of those other kind of things? What about seeing the osteopath or the chiropractor for some manipulation, or the acupuncturist or the massage person? Well, all of those seem to make sense. And certainly they're a lot safer than taking the pain medicines. And we come up with all sorts of ideas about how we can reduce the problem. We reduce the problem by drug monitoring programs, or maybe some databases that the state can maintain, and then the pharmacist can call the database to see if the person is shopping narcotics at different pharmacies. And maybe we're going to have a maximum prescribed dose. Maybe we're going to make some of the drugs incapable of being used for snorting or smoking or injecting. But really what we need to do is we need to focus on the person, and we need to focus on the ability of the person to get back to work, to get back to normal. And unfortunately, long-term use of the narcotics is not doing it. It just isn't cutting it. So as we stand now on the precipice of bringing more pain medicines to market, the focus of attention shouldn't be, do we really need another medicine? Maybe we actually have too much medicine. Maybe we ought to start restricting some of the prescriptions for these pain medicines. Maybe we ought to make sure that there isn't a diversion from the adults to the kids. Maybe we ought to make sure that there's something about our society where people don't crave drug taking. Have lots of issues, and the issues can't simply be taken care of by writing more prescriptions. Anyway, I'm Dr. Ken Landau. Thanks for watching.